So good afternoon, good morning, good evening, dear colleagues. Welcome to this Mycoclinics webinar. Today we have two presentations by opinion leaders in their field. And we are happy that they will join us. So this will be a session with two presentations, and after both presentations there will be opportunity to have a discussion, and you are invited very much to submit questions through the Q&A, and these can only be seen by the moderators, and we will collect those questions, and then we will have the discussion with the presenters. So these Mycoclinic sessions are being recorded, and there's an opportunity to see them later on or share them with other people through the YouTube channel. So today I am chairing the session together with my colleague Tihana Bikanic. She will introduce the second speaker. My name is Paul Vowey, and I will introduce the first speaker. So before I do that, I want to make you aware of the next Mycoclinic sessions. The next one will be in September after the summer holiday, and the 2nd of December will be the last one for this year. So I would like to now introduce the first speaker. I will stop sharing. So the first speaker is Professor Fahal, and he is trained in medicine at the University of Khartoum in Sudan, and he has pursued a postgraduate surgical training in Khartoum and also in London. And he has become a consultant surgeon at the Soba University Hospital, and also a professor of surgery at the University of Khartoum in Sudan. And he is a general surgeon with a special interest and also track record in mycetoma and tropical surgery. So amongst a lot of activities, Professor Fahal is founding director of the MRC, the Mycetoma Research Center at the University of Khartoum. And this center today is recognized globally as a world leader and an authoritative advisor in mycetoma management and research, and is also the only WHO collaborating center on mycetoma. Professor Fahal has also a lot of publications in the area of mycetoma, including peer-reviewed articles, but also many textbooks and chapters, booklets, and clinical guidelines. So we are very happy to have you here, and that you can share with us all your experience and knowledge. And the title of your presentation is Mycetoma Recognition, Diagnostic Tools and Treatment Alternatives. So thank you very much for joining us, Professor Fahal, and please, the floor is yours.
Thank you very much, Mr. Chair. I am very much pleased and honored to be part of this highly reputable meeting, to meet a good number of audience and colleagues and friends, and to be of use for our young colleagues to share some experience on mycetoma. Can I share my slide, please?
Please do. Thank you.
Mr. Chair, my name is Professor Fahal. I'm a professor of surgery, University of Khartoum, Sudan. I'm the director of the Mycetoma Research Center, University of Khartoum, a WHO collaborating center on mycetoma. This is the Mycetoma Research Center in Khartoum. I declare no conflict of interest in this presentation. All images were obtained after written informed consent from patients. The main objective of this presentation is to share experience on unusual complication of mycetoma. 2 cases will be presented and the literature will be reviewed. The first patient I'm going to present, he was a 30-year-old jobless lady from Sinnar State, Sudan. In 25, she stumbled during walking without obvious injury, and that was followed by the appearance of a small, painless swelling in the right big toe that rapidly increased in size. She consulted a traditional healer and multiple skin incisions were done, but that was not very useful. In mycetoma endemic areas, due to poor health education and the low socioeconomic status, many patients depend on the traditional healers to treat them. And this is one of the traditional tools used to treat patients with mycetoma. Some of them will go for a massive incisions like this and got infected, and that caused a lot of problems. Some of them will have a lot of cautery mark like this. And a lot of them will come with many complications. Secondary bacterial infection is one of them. This is a lady with multiple cautery marks, infected, and you can see there is a paste from the local herbs in the region. That lady then consulted a local health center where anti-tetanus toxoid injection was given, but her condition got worse, and she ended in an amputation of the big toe 20 days later. Then 15 days later, following that, she noticed a painless swelling in her popliteal region that gradually increased in size. In 28, multiple sinuses appeared in the swelling and started to discharge black grains. The patient was referred to the Mycetoma Research Center for further management. She had a surgical biopsy, and that revealed evidence of Mycetoma mystomatus, mycetoma, as you can see in this slide. And she was started on 400 milligrams of itraconazole daily and 5 milligrams of folic acid. In 29, the patient had wide local surgical excision of the mass in the popliteal region. However, she stopped treatment as she assumed she was cured. And you can see how massive the mass is. It was recurred in 2012 at the scar site, and it gradually increased in size, and then suddenly it progressed in size to affect the whole region. Then multiple sinuses discharging blood and black grains appeared. She did not seek any medical advice till 2015, where she was seen again at the Mycetoma Research Center. In 2019, she developed dry cough, not responding to medication. And in February 2020, the cough became protective with blood that increased in intensity and frequency. Her condition progressed, and in 2021, she developed central chest pain, which was dull, crushing in nature, and was associated with shortening of breath and palpitation. 3 months later, she experienced lower chest pain. It was sharp, aggravated by coughing and movement, more during night, and that was relieved by analgesics. She had daily low-grade pyrexia for more than 3 years, not more aggravated at night. Then the patient on March 2021, she presented with cough, and the cough became painful, forcible, containing black grains. The cough increased in frequency and interfered badly with her sleep, and she started to cough black grains, and that increased in volume gradually. In March 2021, the cough became very painful, forcible, containing black grains, and the cough increased again in frequency and interfered badly with her sleep, and the cough of the black grain increased gradually again in volume. She developed poor appetite, fatigability, headache, joint pain, and became depressed. And that had a negative psychological impact on her and her family. On clinical examination, the patient looked depressed, emaciated, and wasted. She was not pale, surprisingly, neither jaundice nor cyanose. Head and neck examination was within normal. Her chest examination showed normal chest skin, no sinuses. The right side of the chest was moving less. Tactile vocal resonance were more on the right side. Percussion note was dull on the right lower part of the chest. And there was a decreased air entry on the right side, but no added sound. No abnormality were detected. No abnormality was detected on the cardiovascular, central nervous system, or abdominal examination. This is the local examination. You can see here the right knee revealed multiple non-tender masses affecting the whole region. Lateral side, medial side, anterior and posterior part of the knee joint. And here you can see the masses were studied with multiple sinuses, discharging purulence and seropurulent discharge containing black grains. There were firm inconsistency attached to the skin and deep structures. The knee joint movement were restricted, and the regional inguinal lymph nodes were enlarged, and there were multiple enlarged veins above the popliteal region. We see that in patients with chronic infection and with mycetoma specifically. Again, she had a lot of investigations. Her full blood count was within normal, as well as her renal and hepatic function tests were within normal as well. She had a chest X-ray, and the chest X-ray showed right pleural effusion and evidence of pneumonia. A CT scan was done for her, and again it showed evidence of segmental and lobar pneumonia with a parapneumatic pleural effusion, mainly on the right side. The grains from the cough were obtained and were positive to Medulla mystomatus by PCR examination using specific primers. She was on itraconazole 400 milligrams daily. During her last visit to the MRC, he was started on 1 gram of ceftriaxone intravenously twice daily for 10 days for her chest infection. And that had improved her respiratory system dramatically, but she was still complaining of some cough and black grain discharge. She suddenly developed a right-sided hemiplegia, and a CT scan of the brain was done, and it showed edematous left cerebral hemisphere with a lot of changes suggesting of meningoencephalitis. Sadly, the patient died suddenly, and no postmortem was done for that patient because this is not a practice in this country. This is the first patient I would like to share with you the experience here. The second patient, again, a very interesting problem. He is a 30-year-old male from Kordofan, Western Sudan. He recently presented to the MRC, coughing grains for 2 weeks, associated with recurrent attacks of mild fever, cough, and the cough contained blood once. The patient is known case of right foot mycetoma since 26. His condition started actually 1.5 years prior to his presentation to the MRC at Soba Hospital. In 26, at presentation, he had a painless swelling in his right foot following a sawn break. The swelling gradually increased in size, and then multiple sinuses discharging grains appeared. The swelling was excited as a district clinic near his village. At MRC, he presented with recurrent right foot swelling. It was 10 by 5 centimeters in diameter with active and healed sinuses. Fine needle aspiration for cytology was taken, and it revealed mycetoma infection caused by Madurella mycetomatus. The patient underwent wide local surgical excision, and this is the excised mass. He was given ketoconazole that time. It was the drug of choice at his presentation at a dose of 400 milligrams daily, and recommended to attend the outpatient clinic every 6 weeks for follow-up. But he was lost for follow-up, which is very common in areas where mycetoma is endemic. However, we were not able to trace him. But in 2017, he underwent a below knee amputation for the affected limb because he had uncontrolled infection and secondary bacterial infection. In fact, it was a life-saving procedure. In 2021, he presented again with sinuses of recurrence at the right stump. And here you can see the stump, and you can see the multiple masses and the discharging sinuses. He then developed new masses in the right iliac fossa region and the inguinal region as well. The swelling gradually increased in size, and multiple sinuses appeared, discharging cerebroperitoneal discharge containing black grains. At a recent presentation at the Mycetoma Center on general examination, he looked unwell, pale, vitally he was stable. His pulse, respiratory rate, and blood pressure were within normal. His head and neck examination was unremarkable. His chest examination showed no sign of respiratory distress, no chest deformity. The trachea was normal in position. Both right and left side moved equally. No palpable mass were detected, and chest percussion showed stony dullness in the right middle area of the lung and hyperresonance on the lower left side. There was a decrease in air entry in the lower field and more on the left lung. Crickles over the left side were detected, and a decreased tactile firmness on the lower part of both sets were detected as well. The abdominal examination showed a small mass on the right iliac fossa, 3 by 2 centimeter, and no discharging sinuses. It was not tender on examination, and the rest of the examination was normal, no organomegaly. A 5 by 5 centimeter in diameter mass, which was not tender, located in the right iliac fossa, was detected. And there was active sinuses discharging parent and black grains, and healed sinuses were detected, as you can see here. Local examination of the right low knee amputation stump showed non-tender swelling, 6 by 4 centimeter in diameter, with few non-active sinuses. Other systems were normal on examination. Investigation showed hemoglobin of 8 grams per deciliter, which is low, and the profile of the kidneys and the hip and the liver were within normal. He had a CT scan of both chest and abdomen, and the CT scan of the chest revealed left lower lobe completely replaced by consolidation, with the cavitation lesions containing small scattered grains. Also, the rest of the lung showed multiple small nodules with cavities, irregular outlines, and thickness, while the right lung showed ill-defined nodules in the anterior segment of the right lower lobe. Again, the CT scan showed interesting finding: extension from the lung down to the abdominal cavity, and it showed the mass reaching the upper border of the pancreas. And there was a 44 by 219 mils mass extending from the iliac fossa, and mostly that was the lymph nodes with peripheral enhancements. Another similar right superficial enhancement in inguinal node were seen as well. An incisional biopsy of the right inguinal swelling revealed Mycetoma caused by Medulla mystomatis, and the lymph node showed reactive hyperplasia. Ladies and gentlemen, these are 2 cases of Mycetoma presented with abnormal complication, and that is a lung spread. Pulmonary spread from the Mycetoma is not very common problem, because Mycetoma basically it is a localized chronic granulomatous inflammatory disease. Ladies and gentlemen, Mycetoma, it is a neglected tropical disease, recently included at the WHO list of the neglected disease priorities. As I mentioned, it is a chronic granulomatous inflammatory disease caused by more than 70 causative organisms, characterized by massive deformities and destruction and loss of function if not treated properly and appropriately at the right time. And you can see how massive the Mycetoma in this patient. It is disfiguring and mutilating problem, as you can see here. It can affect the deep structure, organs, and the brain in this patient and can be fatal. And this is a young chap with deeply located mycetoma in the brain and ended with a lot of complication and death of this chap. Here you can see how massive the mycetoma is, because most of the patients are of low socioeconomic status, low health education, have no access to medical care, and hence they come late with advanced disease like this. It frequently affects young adults, the most active member of the society, and that leads to a lot of social, economical impact on the patients, families, and health system in the mycetoma endemic areas. The mycetoma patients are unique. Mycetoma actually affect the poorest of the poor in poor remote areas. Mycetoma is commonly seen in tropical and subtropical regions. It is endemic in many countries: Sudan, Somalia, Senegal, Mauritania, Mexico, and many countries of South America, as well as India, Yemen, Saudi Arabia, and Iran. The diagnosis of mycetoma is not very easy. It needs a combination of investigations. We need first to identify the causative organism to the level of the species. And here we need to have a cytology, a histological examination for a surgical biopsy, and we need serology. And recently, we depend on the molecular techniques to reach the diagnosis of mycetoma to the species level. Very important, we need to know the extent of the infection. And here we use a lot of imaging diagnostic tools. We start by a simple conventional X-ray. An ultrasound examination is important. MRI to see the extent of the infection in the skin, the subcutaneous tissue, deep structure, and the bones, as well as the CT scan to see how badly the bone is affected. This is very interesting slide of a patient with a mycetoma of the foot that extended to the inguinal region, the abdominal cavity, and has spread to the chest. This is one of the 3 reported cases in the medical literature. And here you can see the whole lung, the pleural cavity, were affected by this effusion. And you hardly can see any tissue of the lung in the affected site. This patient badly affected by the infection in the chest, and he died from septicemia some time ago. The treatment of mycetoma is difficult. The current treatment is not very promising, suboptimal, and sometimes is very disappointing. However, the fungal type is difficult to treat, but the bacterial type is much better responding to the treatment. This is a lady with actinomycetoma of the head and neck, and she responded well to a combination of treatment. Currently, we give the patients trimethoprim, augmentin, and folic acid as a first line of treatment. In resistant cases, we give them trimethoprim and amikacin sulfate in a form of cycles. And the cycle is 5 weeks. 3 weeks for amikacin sulfate and 2 weeks rest, and you continue with the trimethoprim for the 5 weeks. We have to check the renal function of these patients and auditory function of this patient every 5 weeks, and then to give the second dose or the second cycle of the treatment. The response is very good, but it will take quite a long time. For the eomycetoma, this is a big a big problem for the patient and for the treating physician. Very few drugs are available for mycetoma. Currently, one drug, and this is the itraconazole, is in place in practice. We start with 6 months treatment with itraconazole, and then surgical excision, and then continue again with the itraconazole until the patient is cured. By cure, we mean that the disappearance of the mass, the sinuses, and the skin changes, ultrasound free of any cavities and grains, and biopsy always should have a negative result. And after the cure, the patient should never be discharged from the clinic. It's always be on the outpatient list, because they may develop recurrence at any time. We saw patients after cure 30 years, and then he developed renal failure, and then he developed recurrence of mycetoma at this site. So we never discharge our patient. We keep them for follow-up in the outpatient clinic. Currently, we are having more than 10,000 patients with mycetoma at the Mycetoma Research Center, and most of them are on regular follow-up. Ladies and gentlemen, I would like to share with you this question. Why these 2 patients presented with this? Both of them are were young patients. They have no other chronic medical problems. The immune system of this patient is quite well and good. And in spite of that, they developed the rapid progression from the toe to the foot, popliteal region, and to the chest. And this is very serious. In the literature, we have 3 patients. They have the same story: aggressive, short duration of the foot, popliteal, and the chest secondaries. Really, it is a puzzle, and we don't know why this presentation is taking place. Ladies and gentlemen, I would like to give some key learning points for our young colleagues. Mycetoma, it is a well-localized subcutaneous infection, yet rarely it can spread to the lung, and the cause is unknown. Lung secondaries may be explained by the vascular spread of the causative organism from the primary cause. Here you can see from the foot to the popliteal region. In one of our patients, we find grains within the vein, within the popliteal veins. Probably from that, they had spread to the lung. Most cases with secondaries in the lung are mycetoma. I have poor prognosis, and all of them, they died. And the treatment is difficult. And in fact, we cannot do surgery for this patient because at the chest, you can see everything is matted together, just like tuberculosis. You cannot excise the mass, and you cannot do a radical surgery for these patients. So we continue our medical treatment, and the medical treatment not very effective, and unfortunately, all of them had died from this. In conclusion, ladies and gentlemen, we are still facing a big problem with the management of mycetoma patients. The treatments for this patient is not very adequate, disappointing, suboptimal, and I think the mycetoma is a scar on the human conscience. And our job is to heal it, as it is one of the non-glorious diseases. And thank you very much for your kind attention. And here is my contact. I'm very happy to answer any queries and comment. Thank you very much, Mr. Chair.
Thank you very much, Professor Fahal, for this very interesting presentation. So I suggest that we move on now to the second presentation, and I'm happy to introduce Tilana to introduce the second speaker.
Hello, good afternoon, good morning, good evening. My name is Tihana Vigilant. I'm an infectious diseases physician and clinical mycologist at St. George's in London. It's my great pleasure to co-chair this session with Paul Fevey and introduce to you the next speaker. We're very lucky to have two specialists in this session, both speaking from the African continent and both very much embedded in their area of clinical practice that's very relevant to mycology. So Professor Mervyn Mair is an academic and a clinician based in the Department of Medicine and the Divisions of Critical Care and Pulmonology at the Charlotte Maxeke Johannesburg Academic Hospital, and also at the University of the Witwatersrand in Johannesburg in South Africa. He's both the clinical lead and the academic head of the critical care unit, and has had a number of publications and is on a number of international guideline making bodies, including being the chairperson of the Global Intensive Care Group of the European Society of Intensive Care Medicine. He's been heavily involved in international surviving sepsis campaign guidelines, and has also authored a number of papers on infection related to critical care in resource-limited settings, particularly in the management of sepsis in resource-limited settings. And on the fungal side, today he will talk to us about one of the causes of sepsis, which is Candida in the ICU. But I note he has also been one of the co-authors of the International Mucormycosis Guidelines, recently published, as well as being the author of a booklet called the Antifungal Pocket Guide for Systemic Fungal Infections. So without further ado, I would like to pass on to Professor Mair to do his talk on Candida and conduits. Thank you.
Thank you so very much, Tiana. It's absolutely wonderful to be here. I'm really honored to be part of this great group on this fabulous Fungal Friday, and very gracious and humble thanks for the opportunity to participate and the very kind invitation. I'm going to just share my screen. Just trying to
We can see your screen, but just not the full screen. We can see the slide.
I'm unable to actually do that currently. I'm just trying to see how I can feasibly get the actual slideshow for you. I apologize. It's let me close this and try again. Gosh, this is, let me see if I can try and
Professor Mair, if you go back into PowerPoint.
Yes.
There we go. And then along the top bar, there's slideshow after animations.
I have that, it's just blocked at the bottom of my screen.
If you can't access the bottom, along the top, you see where it says File, Home, Insert, Draw.
Yes, yes.
So if you go to Slideshow there, okay, and then you should be able to start from beginning or from current slide.
Thank you, thank you. That's wonderful of you. Thank you very, very much. Okay, so in the next 30 minutes, we're going to run through what I refer to as Candida and conduits. We're going to look at some current perspectives, and really what that refers to, the conduits are intravenous catheters. And we're going to try and provide some clarity for the controversies and the conundrums that currently exist and are actually quite prevalent. I spend a lot of time every day trying to read as much as I can about Candida. And if someone said to me, what do you think of Candida? I'm absolutely crazy about it. So these are my disclosures. In fact, nothing really in the past 2.5 years, as all of us have been involved in the COVID-19 issues since March 2020, have been stuck in the unit and really focused fully and absolutely on it. So we're going to run through a couple of issues. I'm briefly going to share 2 cases. We're going to have a look at a brief introduction, look at some of the elements we're all familiar with, but recap them, including epidemiology and risks, morbidity and mortality related to Candida. And then we're going to touch on the debate and controversy related to intravascular catheters. We're going to have a look at the evidence as well. And then we will try and offer some direction and conclude. So we're going to commence with 2 cases, both managed in very reputable institutions. In fact, one of them at an institution outside of Africa, whom I was asked to give some input into. And this was a 68-year-old lady who had had complicated repeat cardiac valve surgery. And post-surgery, she had a very stormy post-operative course, became hemodynamically unstable, developed acute kidney injury requiring hemodialysis. And some days down the line after this very stormy course, a Candida parapsilosis was isolated from her bloodstream. At that point in time, the attending practitioners initiated echinocandin antifungal therapy. And we did debate the issues of changing all her lines at that point in time, but they felt that the guidelines didn't necessarily indicate that should be done. So they continued with the appropriate supportive measures. And over several weeks, the lady had a very stormy course, and sadly and subsequently she demised. Case 2 was that of a 28-year-old lady who'd had a background history of Hodgkin's disease. And she was several weeks post-chemotherapy, and at that point in time in remission from her Hodgkin's lymphoma. And on this occasion, she presented with the right lower lobe pneumonia, which was deemed to be bacterial in nature. She was hypotensive on admission, so effectively had septic shock, necessitating the placement of a central venous catheter. And she was treated with broad spectrum antibiotics. On day 7, she cultured a Candida tropicalis. Once again, echinocandin therapy was commenced. The central venous catheter was not removed, and over a period of days, the patient's condition continued to deteriorate, and she subsequently also sadly demised. Both of these cases had direct links to the medical fraternity, and it's one of the reasons that I share them. So if we go back and have a look at some of the real advances in medicine, intravascular catheters really are currently intrinsic to modern medical practice. They're used to administer fluids, medications, parenteral nutrition, blood products, and they also serve as a useful assistant in terms of helping us to monitor the hemodynamic status of critically ill patients. But just around about 130 years ago, there was very little in the way of vascular access to sustain severely ill patients. In the late 1800s, steel needles became available, and it was really only in the 1920s, with a greater understanding of electrolyte physiology, that intravenous fluid therapy became established. And the next major advance was in 1945, following the advent of penicillin and the need for repetitive administrations of penicillin, and plastic catheters for continuous vascular access were then introduced. And it took about another 22 years, close to the time we put a man on the moon, for long nylon catheters, which were placed into central veins in oncology patients to limit medication-associated phlebitis, for them to come to the fore. And subsequently, further evolutions have occurred with the development of subclavian and jugular vein approaches and newer onset vascular catheters, the focus of which over the last 2 decades has really been trying to make these catheters better, limiting rupture resistance, improving tensile strengths, and making them hostile to potentially invading microorganisms. And so if we look at this major advance, perhaps one of the greatest advances in medicine in the last 150 years, it's certainly brought forth a great advance, but additionally, complications have ensued as well. So what is the magnitude of this problem with the intravascular catheters? To put it into real perspective, around about 600 to 700 million intravascular catheters are sold globally each year. Very important cause of hospital-acquired infections, morbidity and mortality. And for those who are following this globally, in the USA, every single day, around about 130 people die from vascular catheter-related sepsis. And in the UK, I'm sure that the very astute audience and eloquent individuals would know that at least 13 people die every day. In the UK, it costs about £1.5 billion per year. And in the USA, an astronomical figure of around about £30 billion. If we look just at central venous catheters in 2020, the market value of that was $763 million US. So this is a massive issue. If we go back to some of the pragmatic issues, we have a very good understanding of the pathogenesis of these infections. It's largely from the hands of medical personnel, occasionally hub colonization, contaminated infusates, and occasionally hematogenous spread. We talk about various forms of catheter sepsis, catheter colonization, which really refers to colonization of the catheter without seeding, and their laboratory definitions of that, local infection within 2 centimeters of the insertion site, and catheter-related bloodstream infection, which means both the catheter and the blood culture the same pathogen in the absence of any other source. We're all very familiar with the obvious risk factors for invasive candidiasis, and they are listed here. And I highlight intravascular devices, and there are many others. And you would say, well, isn't that really an issue that every sick patient in the hospital has? And the answer is probably yes. So coming from Africa, I like to refer to the risk factors as the big 5. And there we're not talking about lion and leopard and elephant and buffalo and rhinoceros. We're talking about the 5 elements that are most relevant for the development of invasive candidiasis. Patients who are acutely, severely ill, often requiring a prolonged stay. Any invasive procedure, including lines that we've just spent a bit of time chatting about, including being hooked up to dialysis machines, ventilators, and so on. Any major gastrointestinal problem, including acute severe pancreatitis, immunosuppression, both medication, biologics, inherent elements like HIV, and the use of broad-spectrum antibiotics. So with that background, what about the history of Candida in intravenous catheters? Well, this goes back almost around about 60 years, where in 1962, the first description took place. 23 of 29 patients who developed systemic candidiasis were noted to have indwelling vascular catheters. In 1971, almost a decade later, there was a report 25 of 27 cases, and importantly, 89% of the culture positive cases, the catheters were in place for at least 2 weeks. And so as David Denning said in 1993, fungi are flourishing in man, and in fact, even more so, and not just flourishing in man, fungi are fatal in man. And now, beyond that, we are actually seeing the fear of resistance as well. So how common are these candidal infections? And we look at 3 of the biggest acute care studies that were performed. The EPIC study, 4,500 patients, the SOAP study, 3,000 patients, massive studies in Europe, and the EPIC 2 study, around about 15,000 patients, At any one point in time, 15 to 20% of infected patients in the ICU have a fungal infection, largely Candida. This is a fabulous study called the Intensive Care Over Nations study. 10,000 patients, over 80 countries, 730 ICUs, and you can in fact see that at any point in time, a large percentage of patients are in fact on antifungal therapy, that number being in the region of about 17%. And I think this is fabulous data looking at hospital-acquired bloodstream infections and Candida, looking at two different time periods in the USA. And if we look at the former period, 1995 to 2002, you'll see Candida species made up about 10% of bloodstream infections. In the latter era, the more modern era, our current era, around about 1/4. And that far outstrips the increase in the number of pathogens causing bloodstream infections from a bacterial perspective. And so this has brought to the fore a very excellent suggestion that the so-called escape pathogens, which we're all familiar with, pathogens that escape common antibiotics, the C should be changed to CCC to include Candida carbapenem-resistant Enterobacterales and Clostridium difficile. The morbidities are significant. If you look at the data that's out there, in a nutshell, 2.5 weeks to 30 days longer if you survive your candidemia. And the mortalities haven't changed in the last 20 years. We're looking at 35 to 50% mortalities, and this is really a beautiful description of these mortalities. We need to go back and have a look at the real impact of what we are talking about when we look at the prevalence of candidemia in that 15,000 patient study. And I want you to focus on the left-hand bar there with the mortality of Candida being in the region of just over 40%, which far outstrips any gram-positive, any gram-negative, or combined gram-positive, gram-negative infection. And so certainly what David Denning mentioned in 1993, fungi are flourishing, and what I wrote about in 2014, in fact, fatal. We've learned a lot over the past several years about how best to manage candidemia. And in fact, this study from Morel brought to the fore the entity that we need to get in early with antifungal therapy, ideally within 12 hours. If we don't, there's an exponential increase in mortality. And I just want to point out that in fact, prior to the Morel study, Nola Salas in Spain described exactly the same thing 8 years before, and we missed that. Following on this entity, perhaps one of the seminal studies that we need to be familiar with was that from Marin Kolev, where, albeit a retrospective study, I think an absolutely pertinent one for us to understand, where he was able to demonstrate in 224 consecutive patients with septic shock and blood culture positive for Candida species, that not only did you have to add antifungal therapy, you needed appropriate source control. If both of those occurred, mortalities were about 50%. If you did not achieve that within 24 hours, almost all the patients, in fact, succumbed. And if you look at these Kaplan-Meier curves, they're self-explanatory. Combination antifungal therapy plus removal of the catheter resulted in definitively a better outcome. This study, in fact, was followed by a fabulous study by Matteo Bassetti, looking at 216 candidemic patients with septic shock from Italy and Spain. And if you have a look at the red curve, you'll see adequate therapy and source control was far better than adequate therapy, but no source control, or no therapy, or neither source control as well. And so there's been much debate and controversy regarding the removal of central venous catheters. We are all very familiar with the multiple guidelines, consensus statements, expert opinions, studies, and commentaries. And the two guidelines that are most utilized, the ESCMID guideline and the IDSA guideline. In fact, the ESCMID, the former guideline, and there's been an update, an ESICM and ESCMID guideline. In fact, after much debate, they suggested that perhaps catheters should be removed. And the IDSA guideline has suggested that, in fact, one individualize and determine. So subsequent to that, there was a Cochrane database systematic review And in fact, surprisingly, the conclusion of that was that they were unable to provide recommendations or firm conclusions in adult or pediatric patients. And these are some of the terms that have been bandied about in the last couple of years, from controversial issue to evidence lacking to essential step. And so we really are facing a conundrum, which I think shouldn't really be the case. And so let's run through some of the data and have a look and dissect through it and try and offer some direction from an evidence-based perspective. If we look at some of the data that perhaps threw a spanner into the works and created a lot of the controversy, it was this paper published in 2010, looking at 842 patients from two very important randomized controlled trials, the mycofungin versus caspofungin and the mycofungin versus liposomal amphotericin B study. Very eloquent workers, and their conclusion was that early central venous catheter removal was not associated with any clinical benefit. This was just a decade ago. And in fact, they suggested perhaps from a pragmatic perspective, guidelines should consider changing their recommendations. So let's look at what happened at about the same time, which was a study pretty much ignored in a bigger study, a pooled analysis of two large prospective mycofungin trials, the ones that I alluded to earlier, where both survival and treatment success were significantly less likely for non-removal versus removal. In a small initial cancer study, retrospective 92 patients, improved outcomes, significant risk factor if you did not remove the catheter in terms of poor outcome. The Australia Candida survey, which was run over a period of about 5 years, central venous access device removal reduced mortality. This was Monica Slavin's work. And if we have a look at these survival curves, it's obvious that removing the catheter was associated with improved outcome. Isam Raad looked at 404 patients with cancer who also had candidemias and central venous catheters in situ, better outcome with removal before 72 hours. And if we have a look at a fabulous study from Greece, 9 tertiary care Greek hospitals, prospective study, central venous catheters were noted to be an independent risk factor for the development of candidemia mortalities, around about 1 in 2. And they suggest that perhaps we should start considering this as a target for improving outcome. For those of us who work in the ICU, around about 30% of our patients, sometimes more, at any one point in time have acute kidney injury. And this is some fabulous work, 8-year study, demonstrating that prompt antifungal therapy and catheter removal are associated with improved outcome. If we look at this commentary addressing chronic dialysis, in fact, they suggest that adequate source control is mandatory. If we look at the pediatric group, initially a paucity of data, the first study really demonstrating just 70 episodes between the years 1988 and 92 in a large group of dominantly premature infants, and failure to remove the indwelling intravascular catheter was associated with poorer outcome. This was followed by a multi-center cohort of 320 neonatal patients, where delayed catheter removal was associated with increased mortality, but importantly, worse neurodevelopmental outcomes when followed subsequently over weeks to months. And in fact, these authors suggested it wasn't just the potential benefits of early CVC removal, but in fact, if you didn't, there may be neurodevelopmental outcome problems down the line. I think this is an absolutely fabulous study from Turkey. So retrospective analysis in children under the age of 18 with blood culture proven candidemia over many years. And they divided this cohort into 2 groups, less than 3 months and beyond 3 months. And I want you to focus on these figures, which I think are really impressive. A 20.5-fold increase mortality in the less than 3-month group if you fail to remove the catheter, and a 23-fold increased mortality in the beyond 3-month group. And if that was compared just to neutropenia, that value was 3.1, so dramatically increased. And so they concluded it was an essential step to remove the catheter. If we look at longer-term devices, this is a study looking at neutropenic candidemic patients with Candida parapsilosis. No question of doubt, removing these catheters, longer-standing catheters, Hickman lines, Broviac lines, and so-called ports, also associated with more favorable outcomes. I want you to focus on the study from the Children's Hospital of Philadelphia, which I think is another fantastic study. Protracted study over 12 years. They looked at 285 patients with candidemia and central venous catheters in situ, and focus on the following point. If you retained the catheter, this was associated with an increased risk of death on any given day after the candidemia onset. And this was post-adjustment for age and complexity of care at the candidemia onset. And so the suggestion and the conclusion was obvious. Let's look at some large population studies. In Iceland, 20-year population-based epidemiological and clinical study on candidemia between the years 1980 and 1999. Multivariate analysis, strong association between prompt removal and favorable outcome. Canadian study from a tertiary care hospital, 20 years, retention of central venous catheters, a risk for poor outcome. And then going back to Australia, Debbie Marriott's work, where they looked at non-neutropenic ICU patients, and they were actually able to conclude that suboptimal compliance with central venous catheters may result in unfavorable outcome. And they also showed, for those of us who love clinical work, that failure to do ophthalmological examinations was a shortfall. So if we have a look at what Dave Andes presented to us, in fact, just a decade ago, the 1,915 patients from the 7 prospective randomized clinical trials in invasive candidiasis, and I'm sure, I don't know that there will be more. Removal of the central venous catheter was the most important issue associated with survival and greater clinical success, and the only other variable that made a difference was the use of an echinocandin. Subsequently, Matteo Bassetti did a 5-year single center study in Italy, and again was able to demonstrate in all cases who developed candidemia that central venous catheter removal was associated with higher survival. You can see the odds ratios there. This mirrored exactly a Spanish study done by Maria Pay-Gasencio, which was a prospective study, medical and surgical, critically ill patients, 29 hospitals in Spain, large study, 773 cases of candidemia, and look at the mortality, exactly as we described earlier. And what did the multivariate analysis show? That if you remove the central venous catheter in conjunction with early appropriate therapy, you decreased mortality. And here are the survival curves. Appropriate therapy versus delayed or no appropriate combined therapy. Does this extend to anything more? Well, exactly the same data has been shown in burns patients and some brilliant Japanese work looking at bundle care, where the single most important aspect of the bundle care was the removal of the central venous catheter in patients who were candidemic. Single most important element. So in a nutshell, these 7 prospective studies that are available to us have shown us that central venous catheter removal improves outcome, and that catheter retention is a risk factor for persistence of candidemia and higher mortalities. And so it brings me back to the very first study that we began with, that threw the spanner in the works. And in fact, that study was led by Nucci. And it was interesting because if we go back to some of his own work 12 years earlier, 145 patients, catheter retention was found to be an independent variable for increased risk of death in multivariate analysis independent of persistent neutropenia. So what's the rationale for removal? It's to remove the reservoir for Candida species in biofilm and the potential source for persistent candidemia. And I'm often asked, well, you know, it may be easy to tell us that, but there are some pragmatic and practical issues that have to be dealt with. Sometimes not easy to place a catheter. If it's not easy, or guide wire exchange is suitable. You know, what is the role of biofilm and drugs? And if the patient is a patient with a coagulopathy or low platelets, what about the risk of bleeding when you place a new catheter? And in hem-oncology patients, even if you place a new catheter, isn't it the chemotherapy-induced mucositis and the translocation from the gastrointestinal tract more relevant? And I think if there are questions in question time, I can answer each and every single one of these issues and give pragmatic direction. I don't think any of them are a problem at all and can all be adequately addressed. And so as the sun sets on this particular talk, and this is a Johannesburg sunset, even in winter, I'd like to share the elements that I think all of us who love this privileged profession and the ability to work in it every day, do the simple things well. And if you do so, you're likely to have successful outcomes. And so if we have to be pragmatic in 2022, after all the data, all the guidelines, all the consensus documents, all the work that is out there, if we're looking at this particular sphere, we need to have adequate source control. That means if you're candidemic, you need to remove the catheter. In conjunction with that, we need early appropriate antifungal therapy, and we're all familiar that for the vast main of patients, we would continue therapy for 14 days after the last negative blood culture. And then, if feasible, we can step down to oral therapy, which has been shown to be safe, provided you have what I refer to as the 3 S's. The patient is stable, the patient is able to swallow, and you have a susceptibility that is suitable. And for all of these 4 very basic points, there's wonderful evidence to support, in fact, all of them. And so in conclusion, we've been through what I think is most of the evidence out there. When we look at Candida catheter-related bloodstream infections, they're well documented across a spectrum of units, in fact, in every hospital patient. They're associated with high mortalities. We can improve outcomes with prompt antifungal therapy and catheter withdrawal. I've shared their evidence. Life is very, very precious. The 2 cases we discussed at the outset, which were actually related to our fraternity, may still well have been alive. Perhaps if some of these things had been performed, we can make a difference. And the challenge is yours, to all of you out there, and all of ours, to make that difference. And this is a sentiment that I shared a while back, having thought about it and really liking very simple issues and wordplay. Keeping in the line is not fine in this scenario. We need to act and extract, and that's a fact. Our role and a major goal should be to achieve source control. And I hope I've shared that. This very veiled area, I hope we have some clarity and clear vision with now. So perhaps it's very apt to finish off with a very eloquent and wonderful colleague on the African continent. And it's really brilliant, having grown up, worked in Africa and done my training here, and then had the opportunity to travel extensively around the world. And having grown up in South Africa, one of the wonderful things that I had the privilege to see in my lifetime and have exposure to was a statesman who, when history is written, in my opinion, will go down as the greatest statesman that ever did live. And that was Nelson Mandela, who had a lot of wisdom to share, and also to give us ideas of how we can overcome challenges as he did. And many of his quotations resonate very deeply with me, and I'd like to finish off this talk by sharing one of those. And it goes as follows: "It is in your hands to make a difference." And Tiana, I think as an ID specialist, he wasn't talking about infection control. I don't know if anyone out there would like to put into the chat how Nelson Mandela finished the statement, because I think meetings like this embellish what this quotation is all about in the broader sense. And in fact, the wonderful preceding talk embellished it as well. It's in your hands to make a difference, to make this world a better place for all who live in it. And so with that, I'd like to thank you very humbly and very graciously for the opportunity to share just a few thoughts on intravascular devices, central venous catheters, and candidemia, invasive candidiasis. And I hope this has been useful for everyone who's joined today. And once again, my very gracious and humble thanks. Thank you.
Thank you very much, Mervyn, for that moving and passionate talk about catheter removal and its importance. I think I'm now going to hand over to Paul, who is going to start us off in the Q&A and questions for our first speaker.
Yeah, so thanks to both speakers, really interesting presentations. And actually, there are already quite a lot of questions in the chat. So I would start off with the first question to Professor Fahal. And that is, if you are unable to take a biopsy and you want to start treatment, do you, if you give empirical treatment, do you cover both bacteria and fungal organisms?
Thank you. Thank you very much for this important question. I think it is very crucial to answer this. It is difficult to start the treatment without a proper diagnosis for mycetoma patients. And really, we need to go to the level of the species to have the proper diagnosis for these patients. Clinically, you can say this is an eomycetoma and this is an actinomycetoma. But you will come across many cases, very similar presentation. We say that the black grains is commonly due to the fungal type, and the white and the yellow and the red are commonly due to the bacterial type. But we came across a lot of cases with pale green eomycetoma, and they were treated as an actinomycetoma. And this is a very serious problem because it gives the patient drug treatment for a long time. The treatment for mycetoma may last up to few years. So just imagine somebody is giving the drug for 3-4 years, not responding, getting worse, waste of time, wasting resources, and giving the patient the agony of the side effect of these drugs. We came across with patient with fungal mycetoma with yellow grains, which is very common with the actinomycetoma. So empirical treatment is not advisable for these patients. We need to reach a diagnosis. Even at the mycetoma center with the facility for the PCR, we see a lot of challenging cases. So my advice, please don't start the treatment unless you know exactly what is the underlying cause for these mycetoma patients. The patient may have a lot of agony, suffering, and they have a lot of socio-economic impact on the patients and the health system as well.
Okay, well, that's very clear. I think that we really need to make a diagnosis. So another question is about the indications for surgical intervention. So at what point in time do you do that? And is amputation something that is, how do you do that in relation to extensive local debridement?
Okay, the surgical treatment is indicated in all cases of EU mycetoma. Very few cases they respond to medical treatment without surgical intervention. The guidelines at the Mycetoma Center will start for 3 years, for 6 months. Antifungal drugs, specifically itraconazole, in a dose of 400 milligrams per day. After 6 months, we are hoping that the drug may induce a lot of fibrosis, encapsulation around the lesion, and that may make the life of the surgeon easy to excise the mass. And after that, you continue for quite a long time to make sure that there is no evidence of recurrence in this patient. One of the major problems with mycetoma is the recurrence, just like the malignant disease. We think that the mycetoma, it is an inflammatory condition with all the malignant disease behavior, local destruction, recurrence, and a spread to the distant organ at this site. For the bacterial type, rarely we do surgery. We depend on the long-term medication and antibiotics and combination of antibiotics and antimicrobial.
Okay, so maybe we shift now to the second presentation.
Yeah,
what do you think?
Yeah, absolutely. Let's do a couple of questions. So there's one from Dr. Ray Wake, who's also a London-based infectious diseases physician who's also spent time in Gauteng. So Professor Mer, thank you for such a passionate talk. There's been a huge shift towards azole-resistant candidiasis, included Candida auris in Gauteng over recent years. Can you talk briefly about your experience of managing this in an ITU setting, including both infection control and also what antifungal drug therapy specifically you use for these patients?
Well, thank you so much. It's a very relevant question. Candida auris certainly has, come to the fore last, I would say, 5 years. Initially, it was deemed to be the superbug. It's now in South Africa, in my context, probably about the second most common Candida pathogen isolated from the bloodstream. There's virtually not a week in my ICU where we don't see a Candida auris. The risk factors are exactly the same. Just to deal briefly, the infection control and prevention issues, we do try and be somewhat more stringent because it is somewhat more difficult to eradicate. And the early concerns that this was associated with massive mortalities. Mortalities are probably very similar to all other Candida pathogens that we're aware of. The principles of therapy are no different, except that you cannot rely on azole antifungals, except perhaps posaconazole, appears to retain, certainly in our setting. And in Gauteng, Nilesh Govender, who I think is very well known to many of you, already 2, 3, 4 years ago had about 6,000 isolates that were obtained, and we were able to demonstrate some degree of susceptibility to posaconazole, large retention of susceptibility to the echinocandins, although we are seeing more and more reports of emerging resistance, but relatively small, fortunately. And then in terms of amphotericin B, and in South Africa being somewhat resource limited, we don't have access to lipid amphotericins, certainly not in the state sector. So we may rely on conventional deoxycholate amphotericin B, which isn't as amphoterrible. And I mentioned this on this forum. I sometimes think it's amphoterrific to change things. It's how you give it. You can limit and ameliorate all the potential side effects, and we can chat about that should you wish to. And the resistance rates are anything there between 5 and 30%. So our first line therapy would be to obtain source control, exactly as I mentioned. If we have someone with the Candida auris bloodstream infection, the line comes out, all lines come out. And we will treat with an echinocandin antifungal. And in 2019 in South Africa, we published a very extensive Candida auris guideline covering every aspect from the laboratory to the clinical to the infection prevention control elements, as well as stewardship elements. And I was really tasked with the issue of the therapeutics. And so echinocandin antifungals, irrespective of the agent you have available, would be first-line therapy. We chose conventional dosages because in the evolution of that guideline, until time it was published, people didn't know too much about it. But what we do practically, we're using mycofungin, which, for example, I have in our practice with special permission, we double the dose. We use double dose mycofungin. So we would start off with 200 milligrams per day, and we would continue that for the full 14 days. The outcomes are no different at all. We made a particular point in that guideline that if you have candidal septic shock, and again, like the line issues we've just been discussing about, invoked a lot of controversy, we suggested dual therapy if you have candidal septic shock. And that's based on some work from Anand Kumar, which many of you may be familiar with, showing that if you have candidal septic shock and you don't get in early, your mortalities are exceedingly high, and we were very worried in the context of Candida auris. So sometimes we may combine therapy, but we moved away a little from that. We rather give higher dose echinocandin therapy, and the outcomes are very favorable. In fact, during the COVID issues, many of the patients who did, in fact, acquire Candida auris had very favorable outcomes. And so it's not as frightening as it was made out to be at the outset. Tight infection control and prevention measures are really relevant. It is a virulent pathogen. If you look at the data, in fact, it's virulent similar to Candida albicans. There's some actual work on that, which we know is actually a virulent Candida species. And, you know, if we're failing therapy, we go back, we look at source control. If that still fails, we would consider a bigger dose amphotericin B. In the ideal world, that would be 5 milligrams per kilo of a lipid formulation. And most of the patients actually do reasonably. Often it is an indication of the severity of the underlying patient. The risk factors are exactly the same. And there may just also be geographic variation in terms of who and how and the prevalence of this particular pathogen. So in a nutshell, I hope that gives some idea as to our current practice.
Thank you very much. Yes, that was very comprehensive. Paul, did you want to ask another question of Professor Verhouw?
Yes.
Before we round up.
Yes.
So one issue is that the treatment is often refractory in outcome. So you have persistent infection. And one question is, do you find that resistance plays a role in that? Or maybe you have other explanations why, even if you give antifungals, it's really difficult to control the infection?
Yeah, actually, it is a multifactorial for that. It can be the drug resistant, it can be the organism is very virulent and resistant to the infection. It may be the genetical background of the patients, or it can be in the immune status of the patient. So really, it is not only the drug resistant, it is maybe the genetic background of the people, of the affected patients, as well as the immune system. And we are working now on these 3 areas. We are looking into different antifungal and the concentrations of the drugs that we use. And now we're doing a big study on the genetic background of the patient with mycetoma, as well as the immune status of these patients. So really, it is very, very difficult to tell why some of the patients they respond and some of the patients they don't respond to the treatment.
So, and delay, is that also, do they come with advanced disease already often?
Absolutely, absolutely. Patient coming with early disease, localized infection, they have a good outcome. Whereas patients, they come late with massive disease, with bone destruction, secondary bacterial infection, the outcome is definitely very bad, and many of them may end in amputation.
Okay. Tiana, do you have another question?
There is another question for Dr. Mervyn. I mean, it's interesting, you're talking to an audience of mycologists, or I assume mycologists, you know, you're sort of preaching to the converted, probably more so than intensivists, because I don't know about the rest of the world, but certainly in the UK, when somebody has a candidemia, we just tell people to remove the catheter and there's absolutely no argument. There's never any quibbling. Somebody, a colleague from Uganda, Beatrice Achan, is asking how early is early catheter removal. So how early is it, and how do you convince, without giving your full talk, how do you convince your colleagues? How do you get them to do this in South Africa if they're hesitant?
What we do, and thank you very much for that question, and you are correct, because people often follow what is out there, and the current, if you look at pure catheter related guidelines, the current consensus, you can leave them in. Scheduled exchanges and so on are no longer really done. Leave them in for as long as it is necessary, but no longer. And so people tend to follow that, and they have an adage, well, if you're offering appropriate therapy, it may be suitable. What we point out to them is that the whole entity today, antimicrobials are wonderful adjuncts, but if you don't have source control, that's all it is. It's an adjunct. And so with that, the whole mindset often does change. And early means as soon as you feasibly can. If the patient's hemodynamically unstable and they're on vasopressor support, you give a bolus dose of the antifungal through the catheter. You remove it, once you place the new catheter, and you then remove it so that your new catheter is not contaminated. If in fact you can buy a little bit of time and the patient is hemodynamically stable, you remove the catheter and you can administer peripherally for a day or so and then replace the catheter. So there's really no reason, and in my years in the ICU, I can't think of a single patient we've ever failed to find vascular access in. And I know that's sometimes difficult. That's why I touched on the pediatric issues as well, because they say, well, you're an adult intensivist, you come put in this 2-day-old neonate a line. But, if you have to, that's what you've got to do if you want to salvage those patients. So the convincing, it's about teamwork. We're all in this together. And if we do this, we can improve outcomes. And remember, attitude is altitude. If we all have the same attitude and we all incorporate everyone and it's warm and encompassing, we make strides. And so it's not really been an issue, and you change mindsets, and it's in the best interests of great medicine and great clinical care.
Thank you.
Okay, well, I think it's time to wrap up. I really enjoyed both talks. It was really great. And if you look at the chat, a lot of people really appreciate your presentations and also the commitment you have in treating these patients and moving this field forward. So I want to thank you both for your excellent presentations, and also thank Tihana for moderating this with me today. And I want to thank all the participants who joined us today and for their questions. And I hope that you also enjoyed it as much as we did. So thank you all, and I wish you all the best.
Thank you, and also thank you to the organisers at the MRC Centre for Medical Mycology and the silent technical advisors who helped make this happen. And I hope that those of you who are new to Mycoclinics and Mycotalks do subscribe, and there'll be other great talks in store in the future. And as Paul said at the beginning, if your colleagues want to watch these 2 great talks, tell them about it. They can go and watch them. They've been recorded on the YouTube channel, as have previous excellent presentations. So thank you all very much.
Thank you. Thank you very much. Thank you.
Thank you very much.
Thank you.
Bye.
Bye-bye.
Bye.